Now, with your permission, I will start my talk on cataract in surgery in patients with uveitis and in seclusial pupillae. So this is supposed to be the rule of 6. If I have a seclusial pupillae, I will do a yak iridotomy to deepen the chamber and see whether the peripheral chamber also becomes more deeper. The first rule is the indication for surgery is the same as indication for any other eye. When the vision is disturbed or when I feel that the part contributed by the cataract can be set right, I will do the surgery. In addition, cataract removal will help visualization of fundus details. Rule 2. Convention supported by a few case series says that we should control uveitis and wait for 3 months before cataract surgery. This is only convention. You don't have to follow this. You can operate at any time based on your judgment. For example, in intermediate uveitis and Fuchs heterochromic cyclitis, excellent results are obtained after cataract surgery without having a waiting period. Consider starting oral steroids 3 days before surgery and continuing for a period of 10 days. My personal preference, because of the extensive prevalence of diabetes in the South Indian population, I don't like giving oral steroids and I will give only periocular Kenacort. Rule 3, do not use silicone IOL. These patients may need a VR surgery and silicone oil injection in the future. PMMA and acrylic lenses are absolutely fine. Personally, I will never use an acrysoph material in a person with uveitis. The worst patient or worst glistenings and SSNG I ever seen was in a patient with uveitis, a 65-year-old lady. So this is a photograph of that particular person. You can see the severe whitening of the surface of the lens, which is subsurface nano glistening. You can also see extensive changes due to glistening in the body of the lens. Behind the lens, you can see an intact anterior hyaloid face here. This is not my personal opinion. There are many publications, including this one. If you want, you can look into the details. They had expanded these 5 lenses due to glistenings and SSNG. This first patient is a 29-year-old male who had an Alcon 3-piece implant done, who had loss of vision due to changes in the lens. So in uveitis, please avoid the acrysoph material. Rule number 4, please stain the capsule before injecting the OBD or it becomes difficult to stain it. So you'll have to put the dye beyond the area of posterior synechius to stain the peripheral capsule. Please, you can dilate the pupils, you can use viscoelastics, or you can do a sphincterotomy, you can use iris hooks, or you can use a B-hex ring. This will depend on your personal preference and the state of the eye. Always implant the lens inside the bag, don't leave it in the sulcus to avoid uveal irritation. And very, very rarely, especially in patients with JRA, you may need to do a PCC and an anterior vitrectomy. And some surgeons prefer to leave patients with JRA and pediatric cataracts aphakic because of the very high incidence of scarring in these patients. So here we have a patient with a small pupil where the pupillary membrane is being removed. As the membrane is being removed, currently it is 1.5 times what it was when we started. You can use iris hooks or a Mulligan ring even without removing this membrane, but then the chances of destroying the pupillary sphincter is much more like that. When you're using iris hooks, please consider using 5 hooks instead of 4 hooks. We can very well do surgery through 3 hooks or even 4 hooks, but the area that is exposed is much larger for the same amount of distraction of the pupil if you use 5 hooks. This is a movie which was done about 10 years ago, and I'm putting a sub-incisional hook. So sub-incisional hook is very, very useful, especially when you have atrophy of the iris. This diagram shows how with 4 hooks we can do the surgery, but with 5 hooks we get a much larger space. So if you use a sub-incisional hooks both in intraocular floppy iris syndrome as well as in iris with tissue damage, you will not have a loss of uveal tissue outside the wound. Here is one more movie. I thank Dr. Pradeep Mohanto for this particular film. He removes a posterior synechiae with one simple sweep of a simple cannula. The pupil is not fully dilated, is not adequately dilated for him. So he does multiple very small sphincterotomies. These sphincterotomies don't have to be large. He has used intracameral adrenaline as well as multiple small sphincterotomies. So these mini sphincterotomies, 4 or 5 in number, are enough to dilate the pupil to about 5 millimeters, and then he does a very safe surgery in this patient. Here is one more movie from Dr. Pradeep Mohanto. Here he has posterior synechiae. The pupil is quite rigid, it's not dilating. He's attempting viscomydriasis, it has not helped. So he's going to insert a B-hex ring. So the insertion and removal becomes very simple if you have the customized B-hex forceps. This is the correct way to hold the B-hex ring. Insert the distal end, and once it's inside, you can tuck in the distal 1/3 easily, and then the remaining 2 parts. After you have tucked in, you'll get a 5 to 5.5 millimeter pupil through which surgery can be done. Go through the side port to tuck in the last leaflet of the B-hex ring. So B-hex ring will make it very easy and very quick, and you don't have to make the multiple incisions that you have to if you're going to put iris hooks. Then very rarely you may have to do a PCC in patients with juvenile rheumatoid arthritis. These patients are not commonly seen by the private practitioner because big institutions generally manage these patients. You must use other immunomodulators in these patients. Steroid alone may not be enough. Also, please note, if you're having scleritis, don't make a sclerocorneal incision, but make a pure corneal incision. So although this looks difficult, it is actually very easy to do a PCC. And then you can go in with an IA probe and remove the viscode which is there in the patella fossa. You won't lose vitreous. So rule number 5, you must give adequate and prolonged postoperative care. And minimum 8 weeks, you have to apply NSA drops in these patients. Rule 6, please expect excellent post-op results as long as the macula is normal. Before surgery, clearly inform the patient that uveitis is different, cataract is different. Treatment for uveitis will have to continue as before. Thank you.